Hello, everyone, and welcome to the PT on Ice Daily Show. My name is Christina Prevett, and I am one of the division leads and lead faculty in our older adult division. Poor you all, you guys have got me twice in a week. It just ended up working out that pelvic and older adult, my sessions are on the same week. Today, what I want to be talking about is post-operative protocols. I call this a rant because this is an area of practice that really does drive me crazy. And so, kind of zooming out where I want to go, number one is talking about the classic, like what is a postoperative protocol and who often sets it, what this means for physical therapists and for our patients when we are trying to create something that is absolute, that should be relative. And then three, how it has actually hurt our profession with respect to our referral networks based on how the research has been done in this space. First point, when talking about postoperative protocols, these are what the surgeon often prescribes and gives to the rehab team to be done after a surgery. Often and classically done in orthopedics. I'm going to go through like the lens of hip and knee replacements or rotator cuff repairs or ACL reconstruction, where it's a set of like, don't do this for 6 weeks, then do this, then do this, then do that. When we are thinking about a postoperative protocol, number one, it is often set by a member of the medical team that has never actually worked with a person through these protocols. Like that just has to be acknowledged, right? When I'm going to be so sassy this episode, but I would never go to an orthopedic surgeon and say, you should use this scalpel, not that scalpel. And so, in that way, get out of my OR, right? Rehab is my OR. It is my space. I have treated hundreds, if not thousands, of people that have had joint replacements in my career now. I've been in practice for about 11, 12 years. And you know that a protocol as a clinician does not work for everybody. It often doesn't work for many people, right? And what this does, what a protocol does, is it tries to standardize everything. And I'm in research, I understand standardization, but what it doesn't do is give people wiggle room. I have had clients who have crushed and are able to go way faster than the protocol outlines. And I've had people who have had to go real slow because of other things going on in their medical history. When we try and set a protocol that is good for everyone, it ends up being perfect for no one. When we think about protocols, while yes, we have the healing of the actual site that had surgery, that surgical site is never in isolation, right? Our body works as a system. And what we are trying to minimize, especially early postoperatively, is strain on an incision. Strain is a metric of fitness. What is going to be strenuous on somebody who has an excess of lower extremity strength is not going to be strenuous on somebody who isn't. And so, why would we give the same protocol for somebody who is in their 30s getting a knee replacement, who works a blue collar job and is super strong because of all of the occupational lifting that they do, and an 85-year-old who has sarcopenia, has multimorbidity, has been really struggling with high sedentary behavior for many, many years? Like those two joint replacements are not the same. The surgery may be the same, but everything surrounding the person is not the same. What that means is that when we are going into our sessions, the positive for many people is that they think that these are the easy cases because the protocol is set. We just have to follow the protocol and cognitive load goes down. However, one of the things that we have to be aware of is that when we just go by the protocol, some of our clients maybe not getting or not working through steps as quickly as others. And so, for example, I had a patient, younger patient, I'm talking older adult, but I had a patient, he was a ex semi-professional baseball player, labral repair, full rotator cuff reconstruction. And he was a person that was able to get through things a lot quicker. And so, subjectively and objectively, from my assessment, he was doing really well. And so, outside of his like initial protective phases, we kind of went with a symptom provocation model. And he was an ex athlete. So I had to tell him, please don't be dumb. Like, think of me in your head of don't be dumb. But he was doing things like rowing and assault biking and working on floor transfers and stuff way earlier than the protocol had outlined because he was doing better. And his surgeon was like, maybe at the 6-month mark, you'll be back on the golf course. And he was back on the golf course after 3 months. What this did, though, if I would have gone by the protocol, is that athlete would have been so frustrated, and they probably would have been doing a lot more at home that maybe their body wasn't ready for because I wasn't preparing them for that. And what this does is it acknowledges where the wiggle room could be. When it comes to preparing for discharge, the reality is that our protocols are often too slow, especially for individuals who are in that 50 to 65 or 70, where they may still be working, to what their insurance is going to allow and what that is expected of them at home. Right? You may have a person who gets a knee or hip replacement and they have to go back to work in a month and they have a physical job. They may be a grandparent to their younger children's like their grandkids, and they're really putting their kids up in a hard spot if they have to be away for a long period of time. You may have somebody who doesn't have insurance coverage for being off work, or their work doesn't allow them to be off. And so the expectation is that they're going back. Those are all things that may try and get us to be a little bit more aggressive with their care because they have to go back. Like, there is no conversation about, being able to get off for longer. Like, that would be great if it was possible, but it may not be possible. And so, what we start to see in our data is that our surgeons acknowledge that their restrictions and their protocols are not based on evidence informed guidelines. In our pelvic surgery, for example, they have had a restriction of not lifting more than 20 pounds for 6 weeks and nothing in the vagina if it's a vaginal canal surgery for 6 weeks. Only 24% of urogynecological surgeons surveyed believed that those restrictions were based on evidence. And we now have systematic review level evidence that liberal restrictions of nothing in the vagina for 6 weeks and gradually return to activity as your body feels able does not increase risk of complications, reduces symptom burden in the postoperative period, and people report higher satisfaction with their surgical site. The same thing is true after hip replacement, right? We had this theory of theoretical plausibility that they want to limit extremes of motion based on anterior, posterior, or posterior lateral approaches to reduce risk on incisions and stitches. Our data now that includes systematic review evidence from 2015, so this is over 10 years, say that those restrictions do not change the risk of dislocation and complication. And what does is the size of the implant. And yet we are still our hands are shackled behind our back, and we are told that we have to adhere to these restrictions. And then worst case scenario, they never get DC'd or it increases kinesiophobia or fear of movement. And it just creates a downward spiral of cachexia and immobility, leading to sarcopenia and clinically relevant amounts of muscular weakness. So, one, the post-op protocol is often not created by the person who is in the rehab room. Maybe sometimes we have insight from the PT. I don't wanna kind of blanket statement everybody. Number 2 is when we have a protocol that everybody has to use and go in the same order, it doesn't give us the autonomy as doctorate level rehab providers, OT and PT, to use our clinical judgment in order to advance people faster or slower based on how they are presenting. So it really does limit our scope, and it kind of shackles our hands behind our backs, that we can't use our clinical reasoning, which is our superpower when it comes to the comparison of the protocol at home versus in our treatment rooms. And this leads me to our third point. What we have to acknowledge is that in several areas of orthopedics, arthritis is one of them, we have several large RCTs that show no difference between post-operative physical therapy and giving the protocol and having the person do it at home. Why? This becomes so important for two reasons. Number one, of course, there's not going to be any difference, right? If we're following the same protocol, I'm just helping you stretch in many cases, right? Obviously, there's education and stuff that happens around the session, but the magic is in the prescription and the nuance compared to a home exercise program. And so, one, those studies are not actually looking at post-operative rehabilitation within my full scope of practice, right? It is not giving me the autonomy and saying, here, go to PT versus let me give you this standardized HEP for you to follow at home. When we do that, and we have these RCTs now that were based on something that I would consider fundamentally flawed, and we have bundle billing in Medicare in many cases, you would have to make a good argument for referral to post-operative PT because it is taken out of the pot of money for the surgery. And so if this research is saying it doesn't really make a difference, then of course the surgeon isn't going to say, oh, I'm going to take thousands of dollars out of my already cut budget for my surgery to give to the rehab team because I'm only getting paid this X number of dollars for this surgery. So number one, our research is often, and if you look at the authorship team, very rarely is there a PT on the authorship team. It's almost always MD PhDs. And when we are using their protocol and just following it the same as somebody would follow at home, and it's showing that there's no difference between post-operative PT, we are then being de-incentivizing to the physician team to refer to us in the first place. And then we only see the most complicated cases. We're seeing individuals who should have been referred to us a lot earlier and weren't. We're having patients who are frustrated, who know and love and advocate for our profession, who are being told by their doctor to just walk on it, right? And that is because of the way that the research was done. And so, because we have not advocated for ourselves as autonomous providers in the rehab space, like, let me do my job. Thank you so much. You're going to do your job, and then you need to trust me to do my job. It makes it so that in session, we feel like we cannot progress faster or slower. We have to try and go within the protocol and particularly going faster. And then this is the way that the research is done because it mirrors what's been happening in clinical practice. And then our data says post-operative PT doesn't help. Of course it doesn't, right? And so we have this huge loop that is going on, and we need to try and break it. The only way that we are going to be able to break it is, number one, know your worth, right? Know that I am so much more than following a post-op protocol. I have so many more tools in my toolbox. I have seen this so many times, good, bad, and perfectly aligned with the protocol, right? And I know when I can go up and when I can go down. Number two is that we need to understand what this research is saying and how this research was done, because we cannot advocate if we don't understand the nuance of this research to be able to poke holes in it. Number three is we have to try and create relationships with our orthopedic team. And I know this is so much harder said, or so much easier said than done. And oftentimes it's free time and you're already super busy. But what we're going to continue to see is less and less referrals to post-operative PT if this trend continues. And then the fourth one, which I'm going to speak to as well, is that we also need to hold our colleagues accountable, right? I had an orthopedic surgeon say to me that PT in the area with so much passive modalities that they would rather just get them to get a gym membership and actually go. And honestly, fair. If that is what they're doing for PT and they are not getting them bridging to capacity, then they are not doing their job and they would not earn or do not deserve the referral, right? Yes, those modalities are helpful. Yes, we can leverage them. They are short term pain modulators. They can help with recovery of range of motion, but they are not the only. We need to make sure that we are prescribing appropriately dosed exercise in that postoperative period. And that's going to have some wiggle room. A 3x10 of a long arc quad is not going to be what is needed or can be given to every single person who is early post-op knee, right? Like some people are going to be able to do it in standing and do terminal knee extensions, and getting that weight bearing is going to be more appropriate for them, right? We have to be holding the profession accountable, advocating for our profession, OT and PT, though a lot of our research is in physical therapy. And then we also have to be holding ourselves accountable that we are practicing to the height and full scope of our license. All right, everyone, that's all I got. If you are looking for more research in this space and you want to stay up to date with some of these areas of practice, please get on to MMOA Digest. If you have any other questions, please let me know. Otherwise, I will see you all next time.